Hi guys, it's Alistair McKenzie here, sports physiotherapist from the UK, and welcome to Research Unpacked from the Informed Performance podcast. On today's episode, we have part 2 with Dr. Tim McGrath. Tim is a sports physiotherapist from Australia with over 20 years of clinical experience. He completed his PhD from the Research Institute of Sport and Exercise at the University of Canberra on the topic of ACL rehab and returning to sport following knee injury. He is the founder of Elite Rehab, a high-performance sports medicine clinic in Canberra, Australia, and he is also a director of the Australian-based company Pitch Ready, which blends clinical insights with data science to provide squad-based injury prevention and return to sport testing following a lower limb injury. On today's episode, we are following on from part 2 and discussing Tim's second paper titled An Ecological Study of ACL Reconstruction, Part 2. Functional performance tests correlate with return to sport outcomes. This again was published in the Orthopaedic Journal of Sports Medicine in 2017.
This episode of the Informed Performance podcast has been sponsored by Vol Performance, makers of the Force Frame. Used by health and performance professionals for assessing and improving performance and rehabilitation, the Force Frame is a powerful solution for quickly and accurately testing isometric strength and imbalances. In addition to testing athletes, the Force Frame is also used to maintain and improve strength, offering over 130 isometric training protocols. As a portable and easy-to-use system, the Force Frame is designed to ensure every measurement can be accurately and reliably measured, time after time again. To learn more about the Force Frame, visit our sponsor, volperformance.com.
You are listening to Research Unpacked with me, Alistair McKenzie, and here is today's episode with Tim McGrath. Tim, I really enjoyed part 1 and I'm really looking forward to chatting more about your follow-up paper, so thanks for giving up more of your time.
Good. Thanks for having me.
So leading on from part 1 where we discussed your first paper on clinical tests, your follow-up part then sought to correlate functional performance tests with return to sport outcomes following ACL reconstruction, right?
Yeah, it was a pretty massive project, and it was more about I couldn't fit it all into one paper, so I thought it was just a nice sort of way of dividing the two up.
So can you give us a bit of an introduction about what you did in this study and what you explored?
So again, at that point in time, post injury was very time derived. There was a normal expectation around when people should be right to do different sorts of things. So it was very much about kind of trying to quantify recovery at different stages, and also it was probably inadvertent rather than anything else. But then looking, we had the ability of 2 different graft types. We had synthetic grafts, which really have no donor site morbidity, and really at the time they were being sort of tried to be pushed to something where you could get an elite athlete back within a really sort of condensed period of time. So you were really able to just push them functionally as much as anything else. So it really did sort of allow a bit of a indirect comparison between the more classical sort of autograft-based procedure, which is going to have some donor site morbidity, versus one that that is really not a factor at all.
Yeah, we'll get into results, but we discussed previously that the trajectory of recovery is pretty similar despite the graft type, and it's just managing the nuances of the different graft types differently, right?
Absolutely, and it just seemed like if you held up the 2 grafts, there was the synthetic group was a bit higher generally with some of it, but that was just because it was a bias, a bias of the sample group where they just happened to be in a slightly better state before the operation. I don't think it had anything to do with the graft type or anything like that. So it was really about the point that they started at tended to dictate how they went afterwards, as opposed to a hamstring graft was a much slower burn in terms of trying to get some of those kind of functional characteristics back.
Cool. And what functional tests did you look at, and what time points did you look at them? And can you go into a little bit of detail about those?
So we started everywhere from kind of 8, but we did pre-op, which was interesting because people sort of tend to do that from time to time. And the results for those were probably not as useful as I thought that they might be, because there was a real dumbing down effect of even the good leg compared to the operated leg. So you would assume that your good leg is going to do what your leg normally does, and your bad leg is going to be, compromised because it's had an injury. But I would say that the actual non-injured leg was generally dumbed down, or suboptimal compared to the what it would classically be. So I think the body is inherently very good at just kind of just pulling the whole system back. So we did pre-op, and then at monthly intervals after starting from 8 weeks all the way up through to 6 months, and then we sort of then followed them up to how that correlated with return to sport outcomes at 12 months and then the 2-year mark.
Yeah, and that's a really interesting point. And I guess certainly I would assume that when looking at these kind of comparative studies, that the non-injured leg is generally the benchmark of what that limb is capable of prior to injury or at full health and performance. But it would also be sensible to consider that the body will probably have like a centrally mediated response to that injury affecting that limb. So that is really interesting to consider. And then testing wise, you looked at isokinetic testing for quad and hamstring strength, single leg step down onto a force platform, your hop tests and peak speed. So which one of these or any of these would you deem the most useful in approaching readiness to return?
The single biggest thing that came from that data set was that the thing that had the highest correlation with return to sport outcomes was literally just how fast they ran. So we start talking about return to sport tests. Hop tests, for example, feature quite prominently in terms of someone being, ready to return to sport. A lot of those capacity sort of based tests, being ability to absorb and produce force, strength, those sorts of things. They were really, they had a reasonably large sort of effect size in terms of correlation, but it was nowhere near as strong as just simply running fast. So I see those as being foundational sort of measures. I don't see them as being endpoint, right at the very end when someone's sort of going back to sport. So that's how we tend to use that now. Is it's a foundational sort of element to the rehab, that you have a body part that can absorb and produce force. But really, if you're looking at return to sport tests, really the closer something is to the actual endpoint of sport, which is that they have to run fast, they have to change direction, they have to do all those sorts of things, then that test is probably going to be more useful than just literally things that you're going to measure in the gym.
Yeah, and that's interesting. And probably some of those fundamental capacity tests that you describe are quite commonly considered as discharge criteria. Maybe not in sporting institutes, but we aim to, like you said, replicate the demands as close as possible. But also from the athlete's perspective as well, being able to run fast and be agile is probably much more meaningful for them in their stage of readiness compared to these heavily confined tests.
Definitely, and it was a stepping off point to when we started, refining the process towards the skill components that come into like return to sport. So speed is something that features quite prominently in that, because we're trying to, we want to have tests that are, sterile enough so we can compare apples to apples, but not so sterile that they get removed from the end goal, which is, return to sport. So speed is a nice, easy way of creating enough duress to really sort of test the system, but in a controlled enough manner that you can, really get a much more sort of controllable situation when you're trying to work out, is someone, how do they actually perform?
Yeah, and we're lucky enough to use GPS to guide our exposures to different running loads, and that's what you used in this study. But I appreciate, as you do, that not all of us will have access to that data. So what would you recommend if you had no GPS system, but you wanted to test their peak speed capacity? Would you literally do a stopwatch and a couple of cones kind of job, or what would you recommend?
Yeah, I mean, I feel like I'm a bit of an old dinosaur sometimes, because, GPS really came in sort of, I'd been in professional sport for about, I don't know, maybe 5 or 6 years before GPS was even a thing. So it's almost like I got my first mobile phone when I was at university. So what did we sort of do before that? So, prior to that, it was all hand timed, and you can sort of argue the merits of whether that's accurate or not. But subjectivity is really quite an accurate thing at the end of the day. And as long as you can have confidence in what someone is actually telling you at the end of the day, then that can be really as good information as anything else. So someone having a perception that they're running really fast is generally probably pretty close to the fact that they were, running fast or not. And if it is a more experienced athlete, then they generally know their body pretty well, and they will give you pretty good information most of the time.
Yeah, great answer. And it reminds me of a time my old club doctor, who was working with England Rugby at the time, said to me once that the data will only get you so far, and the subjectivity or their perception and confidence will ultimately lead the decision-making process when you near return. And if that player is holding back or hesitant during a linear sprint, then regardless of data, you know they're probably not ready yet.
And a lot of the skill components is about trying to, like when you're trying to problem solve that, it can be lack of capacity, it can be fear, because a lot of the positions that an athlete will adopt with things like, high speed change of direction is their method of protecting their body is actually probably more dangerous than what they sort of realize. So it's a good question. You see things which we know are kind of aberrant or dangerous, and then that is literally one of the questions, like were you concerned? And because you're trying to work out if it is literally a skill acquisition problem, like that's been a motor pattern, if you like, or a skill has been allowed to sort of linger too long in the rehab, versus it's a lack of capacity, so they just don't have the ability to absorb and produce force, or it can just literally be fear. They don't trust their body. So it's about, each of those from a management point of view is probably going to have a very different means of attacking it. And I think the best rehab programs are the ones that can be a bit more targeted in that regard, not just make assumptions that the reason why someone's doing that is for a given, one given reason.
Yeah, and that brings us on nicely to the pitch ready work, and I really want to find out more about what you do there. But before we move on, I just want to sum up this paper, similar to what we did as part one. So if you had a couple of clinicians, either physios or strength coaching, reading this paper, what would some of the key points that you would like them to take away from?
I think the biggest one is just that the more the closer your test is to sort of the end goal, is probably the more useful it's going to be. So when you're looking at sort of measures of capacity, they're probably only mid-stage kind of indicators, if you like. That I don't see them as being the endpoint for sure. And symmetry is a feature that often gets talked about, and people being within a certain percentage of their body. When we're talking about measures of capacity, which is very much what that paper was about, if it comes to a debate between symmetry versus absolute numbers, relative to that demographic that you're talking about, if someone is asymmetrical but within a peer group sort of level, then I would take that any day of the week.
Yeah, and that's a good point. I think we are at risk trying to chase symmetries all the time with some tests, and I think it's easy to get lost in that pursuit. So what you're saying is, as long as the absolute strength of the injured limb is above the desired benchmark, you can probably be quite comfortable in that and then move on to the next.
Yeah, and I'm not scared by it generally. Like, as if they're within a good tolerance from an absolute point of view, then I haven't been burned by sort of letting that ride. On average, in terms of performance tests specifically, not skill-based ones, they tend to be pretty close to the mark to each other. So on a general level, I'd say that most people are symmetrical. But having said that, from a like a return to sport feature, it's not a deal breaker for me, for sure.
Yeah, fantastic, mate. And it's a really great paper. But hearing you talk about it really comes across the the clinical side or the practical side of this knowledge. So I know that there's some real cool clinical pearls in there that I'll certainly take away, and they'll inform my practice from now on. But hopefully the listeners, I'm sure, will find the same. So thanks a lot for that. But let's talk about Pitch Ready. What's your day-to-day kind of job at Pitch Ready, and what do you do over there?
So the way people that know me know that I love an analogy and probably get bored by it at the end of the day, but it's the only way that I can sort of try and explain things most times. So Pitch Ready really is looking at two. You know, if you're a racing car team, you've got two components to it. You've got the racing car driver, and you've got the racing car itself. So in terms of an athlete, all the racing car itself is all the bits that make him, strong and powerful and fast. So, strength, power, all those sort of physical qualities that don't necessarily relate to a skill base necessarily. They're more just your general sort of athletic qualities. And then the racing car driver itself is, the ability to sort of go around a track at 180 kilometers an hour or whatever the miles per hour version is, and not crash into the wall. So if you're driving a car at 60 kilometers an hour around the track, then you can have a blood alcohol that's sort of 3 times the legal limit. And if you've been driving for a little while, you won't crash the car. As opposed to, when you go down a track really, really quick, it's all this feed forward kind of aspects where your body has to process information really quickly, and it doesn't really have time to think. It's all just reaction. So really the skill component for me is, trying to get estimates of that in terms of people's, that sort of feed forward mechanism. Because when you start talking about mechanisms of ACL, for example, the time period from foot contact to when they do their knee is about 40 milliseconds, and your brain's ability to work out what just happened is something around, 200 to 500 milliseconds. So it's miles after the fact. So when you're rehabbing people, you have to try and find ways of hard coding in movement preferences, if you like, which don't set them up for fail. And it does trigger a lot of debate in terms of, how much can you change someone and what's meaningful and what's not and all those sorts of things. But for me, it's just big rocks. It's not, it's really, there's a couple of key things that I think are important in terms of, injury reduction and return to sport, which if they don't have those in place, then they're traditionally really, really high risk. So it's really just about trying to get the big rocks in place, if you like, from a skill point of view. But really for Pitch Ready, it's really about just trying to get as many of those two, big pillars in place as you can, and then from that, then being able to be targeted with your intervention. So programs like the FIFA 11, for example, are by nature designed to be big and broad and covering off on a lot of the things that we know are important in terms of injury prevention. There's no ability for dose response. So exposing someone to, an intervention doesn't necessarily mean that they respond to that. And from all other aspects of programming, there's, lots of roads lead to Rome. And it's really, if someone responds to that, then great. If they don't, then you need to change your intervention, but it doesn't guarantee that just because you expose them to that single thing that it's going to change it. And likewise, from a return to sport aspect, it's really about saving your battery of testing to the end point right before they go back to sport. I think has some real limitations, and it's because if they're all within a good normal space across all the spectrum of things that we know that go into re-injury risk, then you probably didn't need to test them in the first place because they probably would have been fine. It's really about trying to make yourself feel better about it at the end of the day. But in terms of if something is outside of a normal range and it's important, leaving it right till the end means that you've got no time to do anything about it anyway. So classically, they've already told, the medical staff have already told the coach that they're due back in 2 weeks or something like that. So really, most of the time they probably roll the dice. So what was the point in sort of trying to get any objectivity around it? So I think it's much better to bring all those aspects in a lot earlier in the piece, and then try and, just surviving rehab is not a good metric for me in terms of, how they're coping within rehab. So it's really about looking at these big pillars that can be important within the rehab spectrum, and then not only ensuring that they are safe, but helping from a programming point of view as well, where you can really be as targeted as humanly possible. So it helps me from a programming point of view, not just from a risk assessment, but really about when I'm trying to rehab someone, what are the most important things that I want to try and get into their week.
Yeah. So can you provide like an overview, maybe a summary of some of your pillars of rehab or pillars of performance that you just discussed then?
I really like, again, within those two broad themes. So if we're talking about your leg capacity, like, I tend to think of it like with those other papers we were talking about, is a lot of the functional milestones I think about like a totem pole. So you've got to get your foundational strength things in place first. Then you can sort of start shifting things on that sort of power continuum. So once they've got ability of the knee to tolerate compressive load, so I don't do isokinetics anymore. Literally just biomechanics of repeat single leg squatting is enough, because it just shows that the knee demonstrates that the knees can tolerate that compressive load. And then foundational sort of hip, groin, hamstring, calf strength. Because from the mechanical point of view, we're trying to find ways of unloading the knee, and an easy way of doing that is, ankle stiffness and load being attenuated at the calf. And that can be a foreign stimulus for people. So if they have, they don't have good calf capacity, then you can start creating, soleus strains and, all those sorts of things. And then same thing with hamstring is that, it's important for generation of speed. So once you've got like we said with that first one, nice happy knee that's, tolerating the exposure, then that kind of foundational strength generally across the body. Then it's more about sort of concentric power, so producing force, not necessarily the absorption part just yet. Then it becomes about kind of absorbing and producing it, so that and then doing it really quickly. Then from the skill aspect, it's really if you look at the big pillars of injury mechanisms, it's generally foot going wide of center of mass. When they decelerate, nothing is attenuated at the ankle. So if you look at most people hurting their knee, they decelerate with their contralateral leg. Their leg ends up, because if they're trying to generate, stepping in a direction, but the inside leg is the big braking leg, that really forces their leg to go really wide. So the ability to heavily decelerate on that ipsilateral side is really quite important. And at the end of the day, the bit that really dictates if they do their knee or not is where it's positioned in space at the point of foot contact. So if someone has, combinations of low knee flexion, valgus, internal rotation at foot contact, then especially if it's in a fairly controlled situation, then it's only going to, potentially need another one or two layers of chaos that sport provides that's going to potentially unravel them. And if a question always comes, well, okay, why that moment? Why did that, they stepped 1,000 times, like why did it happen that one particular time? And for me, and it hasn't been disproven yet when you actually talk to the athlete, is, what was foreign about that moment? And usually it's about pressure or something that just forced them into that kind of 180k an hour scenario that their body made a choice and it didn't necessarily make a good one. So it's in a rehab setting, it's about trying to prepare them literally for almost that worst case scenario. So it really needs to be something quite chaotic for those that kind of mechanism to leak out.
Yeah, fantastic, mate. Fantastic answer. And it shows, again, all the combination of your clinical expertise with the research side of it. So really enjoyed listening to that. And speaking about the research, I know you are the Director of Research for Pitch Ready as well. So can you give any insight into some of the studies you're conducting or about to publish and so on?
Yeah, so it's really about, like I said, these two pillars. And what we've been doing is when I finished my PhD, I went and did a computer science degree because the further down this project that I got, the bigger the data sets we're getting, and I tried to get lots of help from computer scientists in terms of getting, you start getting into biomechanical data, and you're sampling at sort of 200 hertz upwards, so the volume of data can get out of control really, really quickly. And it used to take me 5 or 6 hours just to process kind of one person's data. So it was about trying to be able to pull all this information together really quickly, and you need to be able to understand coding to be able to do that. So since we built the Pitchery platform, like we pull it all into the single sort of single area, and then that enables us to be able to kind of run insights against how all these variables compare, and then general performance related metrics. So what we're working on now is totally blinded. So just looking purely at the data. So remove the human aspect. What's my ability to kind of predict which one was their injured leg, in a return to sport setting, just based purely in the data. So knowing nothing about which one's their injured leg and all that sort of stuff. And really looking at those two, what's the power in both of those two forms of tests. So a bit like how does clinical tests compare to functional tests? Now it's really about, how does skill-based tests compare to your classical capacity-based tests? And if someone's inside a normal range compared to that peer population, how does that compare to re-injury rates when they sort of go back out into the real world? And so far, the way that's kind of panning out is normalizing your leg capacity does lower your risk, quite noticeably. Like I think the people who've normalized that capacity bit alone, the re-injury rate historically, we've got sort of around 700 athletes now, so reasonable data set. And the re-injury rate for those is sort of a bit over 3.5%. So pretty good when you compare to some of the populations you'll read about. US colleges around 20%. The AFL 15-year rate is around sort of something around 30%. As where the skill components, for people who normalise those skill components, the re-injury rate is uber low. Like we, haven't really had one re-injured. There was questionably one guy that went back and played for 12 months with, like, it had a mechanism. We got data on him on the back end, and he played a full year of competitive stuff and then had a mechanism sort of 12 months later. So for me, there's some aspects around, did he remain normal and all that sort of stuff? But he would be the only one out of that whole population that has normalized the skill-based components that we've had a re-injury. The ones that haven't normalized, as in we don't have evidence of it, and COVID created some challenges there where they couldn't get repeat testing because everyone's in bubbles and all that sort of stuff. Or they just did one test and it was right at the end. But the re-injury rate for ones that normalise skill, like I said, is potentially we've had one and questionably none, as where the re-injury rate is around 22% for ones that we don't have evidence of normality for. So the probability of predicting that is, up around sort of 90% as well, of which is their injured leg. So it's washing out that the skill-based components are much more powerful in terms of determining readiness for return to sport, and even on the pre-injury side, like a lot of the things that we sort of looked at that eked out in a post-injury sense, you tend to see them pre-injury. So that's the big focus for us now, is in trying to actually get them before they actually hurt themselves, rather than having to try and get involved. Is actually after the fact, is really about trying to stop them before they happen. So so really it's about sort of a bit like clinical tests compared to functional tests. It's leaking that the closer the test is to the endpoint is really where the power in that data lies.
Yeah, and that's some pretty impressive numbers, mate, with over 700 athletes and really confident outcomes.
So like I'm it's at the point now where I'm really quite confident in the data. Like, there's multiple instances where I've had zero input into the actual rehab. Like, it's professional teams that the medical staff are looking after the athlete and really, and they're looking for some guidance as to where they sit in terms of that in terms of that spectrum. My level of confidence with it is, getting stronger sort of all the time, where between, literally about making the complicated as black and white as humanly possible.
Yeah, so the team collects the data, puts it through Pitch Ready, puts it through the platform, and you kind of oversee like a consultancy role, help them inform or make decisions based on the data.
Yeah, so for instance, like there's an NBA team that I was going to go over there and try and help them with some things. That challenges with COVID meant that couldn't do that. So it's within the realms of them, sourcing equipment and that sort of stuff. Then the end goal is that they can capture the data themselves independently, and then really the platform itself automatically reports on, for that population, where they sit in terms of normality, and then has some general recommendations in terms of things that to work on with all those big broad themes that we were talking about. And then really my job is to try and a lot of these staff that are working with it, they're smart, they're super smart people in themselves. So it's really, you really only have to go into the theme base. Like for me, it's this theme, and you'll have your preferential drill for that particular theme. For me, my favorite drill is this, and it's really about just trying to make it applicable at the back end of it. So I've come from places where you're collecting all sorts of data and using none of it. So really, that's the opposite of what I want, which is anything you collect is usable, and implemented within the program. So really, that's we in Australia we collect data. Overseas, we get places to have their own ability to capture data and train them how to be able to do that. And then really mine is just to try and help them get as good an outcome out of that as possible. The classic consultant thing is that they try and make themselves the center of the universe. I don't want that. It's the process is what I'm most interested in, and it's very much about trying to train people in how to use it and understand it, as opposed to trying to make myself the center of the universe with it all.
Yeah, and you said before, listeners can stay up to date with the research and the work that you're doing with Pitch Ready on Twitter quite a lot of the time. Is that right?
Definitely, yeah. So that's where a lot of the stuff that we're reading at that given point in time that's where we, a lot of the time I just retweet stuff just so I can go and have a read of it myself afterwards. So, that's the fair assumption, is that what's on there is basically the stuff that I'm reading at any given time.
Yeah, fantastic, mate. And that brings us nicely to the end of part 2. So thanks again, Tim, for coming on to the show. Really enjoyed our conversation. Loads of excellent clinical and research-based insights that I found really useful, and I'm sure our listeners have as well.
No worries. Anytime.
I'd like to say a big thank you to Tim again for coming on today's show and providing us with even more excellent clinical tips and how to manage athletes back following a serious knee injury. So please stay tuned for part 3, where me and Tim discuss a more recent paper of his that looks on the determinants of hamstring fascicle length in professional rugby league athletes. To find more Informed Performance content, head to informedperformance.com, where you can find all our episodes as well as articles and courses from top professionals in performance and sports medicine. And don't forget to follow us on social media at Informed Performance on Instagram or at InformedPod on Twitter. Thanks for listening to today's episode of Research Unpacked. Catch us next time for some more performance and sports medicine insights.